Good afternoon. Pierre and I are going to be doing a session today on sedation and analgesia for an ICU patient. I'm Marek Mirski. I'm from Johns Hopkins, Baltimore.
And I am Pierre Bouzat. I'm coming from Grenoble University Hospital in France. So it's a great pleasure to be here. So this session is thought to be very informal. So we have to talk together because I think if only we are talking both of us, it will be not okay. So we want you to participate, and we hope that we'll enjoy the session. So just for us, what is your background? How many of you are anesthesiologists? Okay. Working in neurological care? Or? Okay. Okay, almost. Yes. Okay.
Good. So we're going to be looking for your input to see how you address some of the issues, because Pierre and I haven't involved ourselves at all in this, so just kidding. This is the case scenario to begin with, just for thoughts. A 63-year-old male admitted to the ICU from the interventional neuroradiology suite following a same-day coil embolization of a left ACOM aneurysm to treat a subarachnoid hemorrhage of that grade. Patient was admitted through the ER with symptoms of headache and diminished sensorium and had a GCS of 11. So when he was admitted to the ICU, intraventricular catheter was placed because of the need for CT evidence of pending hydrocephalus. So during this time, he developed a probable lung-based pneumonia during the initial 2 days he was there, and ultimately required to be intubated and then placed on the ventilator. Following all this, he was arousable, still following commands, without any focal deficits. That's all good. But was also agitated and required some analgesia sedation for the fact that he was being assisted mechanically and potentially for some neuro issues. But that's up to you all to figure out. TCDs were done, which were normal, but there was a concern by 2 days later on day 4 that the velocities had increased a little bit, so there's a concern ultimately for vasospasm. But at this time, he was arousable following commands. But he continued to be restless, pulling at his endotracheal tube, just being sort of unsafe to himself. So the critical care team decided that they needed to have a sedation plan. So this is not an easy patient. There are many issues here. So the question to start with is, what's of concern to you about this patient in terms of thinking about how to address a sedation anxiolysis plan?
Okay, so it's your turn. Maybe we can go back to the clinical case so we can have, if maybe someone in the audience want to comment. Yeah, you would want the microphone, maybe it would be easier.
So you've mentioned the TCDs are slightly raised. Have you done a CTA and have you excluded vasospasm or DCI?
Well, CTA hasn't been done yet. CTA has not yet been done, but the indirect evidence from the TCDs is that there's at least elevation velocities, which could certainly be the prelude to true spasm, if you will, radiographically.
Yeah.
Yes.
So you would probably just endotracheal tube safety plus the degree of vegetation and maybe the CNX excitation resulting from that versus the need for evaluation, neurological evaluation, just something that is short-lived in the circulation so you can actually continue to assess the patient continuously.
Right. No, exactly right. And this is sort of a cheat sheet of some of the things you might be thinking about. Again, this is the easiest patient with just 1 or 2 little problems. This is a patient with several, and these all have to be put together to decide how and best to provide sedation. So there's some agitation, there's maybe some hydrocephalus that's coming on, possible vasospasm, causing cognitive changes, maybe some delirium. But you are concerned that he's coiled and not fully sort of fixed, and so true aggressive agitation you certainly want to avoid. And he's mechanically assisted, so that's also a concern, that he's agitated from that. But above all, you want to follow the patient along, which much of that in the sort of neuro ICU setting is an examination should be able to be permitted to be done on a every few hours or a daily basis to assess the status of the patient.
Plus, maybe you don't want him to be too hypotensive as well. So you want the hemodynamic profile to stay stable with a subarachnoid patient.
So the safety profile of any drugs that you decide that you want to implement have to be, you have to be concerned about cerebral perfusion, which is the end all for most neuro things. So, given all that, when you're thinking about your armamentarium of pharmacology that you have, what are the desired drug attributes that you're thinking of?
Norepinephrine, first of all. Sedation or general, you asking? For this patient. I would give him or her sedation with midazolam and fentanyl mixed. Norepinephrine for arterial blood pressure to maintain about 160. Anticonvulsants. Euvolemia, of course. Basically, this we have not to miss these medicines.
So why do you want to give midazolam?
Sorry?
You said you wanted to give midazolam,
Yeah.
yes? Why?
Because
Was that a good drug in this case?
I wouldn't agree because midazolam may worsen delirium if there is an underlying condition because he may have pain or distress. We would use dexmedetomidine. We use it except if the case should be sedated because of his respiratory tract. I mean, we had to do recruitments and so on. But Dexdor with dexmedetomidine would allow us to assess the status of the central nervous system and may also help with delirium, which may be the underlying condition, and also has some pain and may contribute to pain management.
Some analgesia.
Analgesia, yes.
Great.
Probably.
But before we get into the drugs themselves, is there anything we can add to this list, or is this list comprehensively about what we're thinking in general about the medication we'd want to use, or medications? And we want to assess neurological exam, which you brought up, which,
Short acting.
if you're looking at this list, then your midazolam doesn't seem so perfect anymore, even though midazolam is the #1 sedative in ICUs across the world, no doubt.
it is not just delirium. There is a vasospasm, and this patient needs sedation several days, I think.
Okay, so you're thinking this patient's going to need sedation for more than a few hours?
Yes.
Correct. Okay. So you need a drug that is effective acutely, titratable, presumably short-acting, so that when you turn it off, you can assess the patient better.
I think the choice of the sedative agent depends on what is the underlying condition of the patient. If the patient is at risk of having intracranial hypertension or severe vasospasm with huge consequences in the brain, so maybe you will have to sedate the patient for a long duration. But until now, we still don't know if there is a vasospasm because finally the patient is more likely to be sedated due to the respiratory condition rather than the neurological condition until now. Okay, I think this is the main point of the case. It depends on what is happening right now. If it's only the respiratory condition, so you have to perform light sedation so you can make the neurological exam. If the patient needs to be sedated to protect the brain, so you have to use deeper sedation and higher dose of sedation. I think this is the main point of the choice of the sedative agent and the strategy you have.
Yes. So this is all just formulating your strategy. Whenever you embark on a plan, the first thing to do is ask what the plan should accomplish. And this patient, being complex as it is, has these sort of issues that I think everyone would agree that you need to take into account when you're thinking about selecting a pharmacological plan for the patient, right? You mentioned very nicely we want a hemodynamically stable drug regimen, okay? So, you know, a big propofol drip probably just doesn't compute very well at the time. You want something short-acting, you're not going to give a 2-day acting drug that you're not going to be able to then assess the patient potentially. So titratable, patient may have, you know, intracranial hypertension, maybe going into vasospasm as well, so the perfusion plus keeping ICP manageable, assuming the drain isn't always open. And above all, you know, you can do any type of testing you want on a patient in the ICU for neurological issues. You know, CT, EEG, we mentioned the TCD and the CTA. But the number one most precise, subtle examination is the bedside neurological exam.
Yeah.
You lose that, you lose a large component of your ability to track a patient. So obviously, if possible, your sedation plan should try to maintain the neurological exam. So this all has to go into your...
Maybe remimazolam would be better agent for short-acting sedation in this patient.
So I think we've answered some of this, is that why you want to sedate. First, that's another sort of question you have to answer for yourself, because maybe they don't need it. Not everyone who is intubated needs to be sedated. Some patients tolerate, and particularly in neuro, if they don't need it, don't do it, is kind of the guide. But we sort of described a scenario where the patient needs something. You know, they're grabbing for the tube, it's going to change their blood pressure, they have a coiled but not fully secured aneurysm. So all the things are there to say the patient needs to be managed somehow. But before we get to the actual drugs, again, the other issue is when we talk about sedation, we have to ask ourselves, what do we mean? Is it, as you were talking about, is it patient anxiolysis? Is it just patient nervous, looking around? Is it delirium you're wanting to treat? Is the patient in pain? Maybe all they need is a little fentanyl drip and off you go and you're done. So asking what the patient might require and what the nursing team may require or the physician team may require in the patient all come in together as to sort of deciding finally what you want to do. And some medications offer one of these, and some others have more complex composite mechanisms, and so some...
I'm just saying it may be a combination also of drugs with low dose. It doesn't have to
Of
be
course.
just one drug.
That's what I'm saying, right. But that's, you're going to develop a recipe. It may be just one drug does 5 things, or you need 5 drugs to do 5 things. But this helps you figure out what are at least the components that you're asking your drug regimen to do. Okay. So this is just sort of looking through what do you want to do with a patient. Asking yourself why they're delirious. And this is one of the... So before we get to that, maybe we can go around and ask, when you decide to treat delirium or need to sedate patients, what kind of things do you want to rule out? Why is the patient pulling at his tube? What are other things that may cause a patient to be hyperactive and agitated? Pardon?
Saying maybe just discomfort.
Of course, could be just discomfort. But when you decide to embark on treating a patient with active medication, what are some of the things you really should think about to rule out? Because sometimes the agitation may be just an expression of something underlying that's not good. And just covering that with sedation is a mistake.
Obstruction, maybe? Urinary obstruction, I would check the
Sure,
catheter.
could be. Hopefully this patient has a Foley in, but of course, simple things, acidosis, hypercapnia. Well, yeah, and here's just a sort of a possible list of things to worry about when patients present with feeling you need to treat them for something. Right? These certainly cause patients to be anxious, pulling at things if they're hypoxic, but even some of the lower ones, patients been in the hospital already now 4 days plus. Some of these other things could be already embarking on a course to cause the patient to have cognitive changes, and that turns into delirium and agitation. So just a thought to consider as things you may think about. Also, they're on drugs. Drugs sometimes themselves cause agitation, delirium. So looking through their med list to say, geez, maybe they are on steroids and just hyped up. Yeah. Or they could be on some other drugs that sometimes can do this.
Yes, so we're talking right now about the way we can assess the level of sedation in your patients. I don't know which scale you use routinely in your ICU. Maybe someone want Richmond Agitation scale. So I think we all agree with this is the next slide. And obviously we have this RAS scale. What would be I think your aim for this patient? What level? 0, okay. But of course. So alert and calm, okay? This is alert and calm. This is the main objective of the situation right now. Okay. I think we all agree.
A point I just added here is just remember, again, this is a neurologically sensitive patient. The RAS does not have anything about cognitive capability. You're just assessing here how much they're basically moving about and how well they respond to nudging them and seeing if they start moving. So this would be probably insufficient for your medical team to be satisfied with to sort of gauge their sedation level, because if they're at even a RAS of 0, but they're not answering to you, perhaps they could answer to you if they weren't on some medication that you gave, or it's the wrong medication. Maybe, again, not to pick on you, but midazolam could cause them to be cognitively very poor, even though they're awake and calm. But then you're worried about the patient was able to count to 10 4 hours ago, now they can't. Is that neurologically deterioration because of vasospasm, ischemia that I'm not aware of, or is it a drug effect? So picking drugs that have the least amount of impact on the neurocognitive would be a good line of thought here.
And would you use another scale than RAS? Wondering whether we can use a pain scale as well? No?
Yeah.
Just to adapt. It's only sedation here. There's no action on analgesia here. So we can combine RAS with BPS, I don't know.
Yeah. Behavioral, you mean pain score?
Right, yeah. Behavioral pain scale.
Little funny face. Right?
Yeah.
And just another aside on this, RAS is the most validated sedation scoring for the ICU, no doubt. I'm not sure it would have been there if it wasn't one of the first, because it doesn't do anything about how well a patient's doing in terms of brain function, but also it is a complicated scale, because I'm not sure you're aware, unless you look at it, that it's an asymmetric scale. It's got 5 levels below 0 and only 4 above. So it makes it intrinsically a little bit difficult to keep in your mind. Like if I cover the screen up and ask you what a RAS of -3 was, how many of you would be able to say, oh, this is exactly the type of patient I'm envisioning? It's hard. It'd be much more easier if it was a symmetric 1+ is a little bit bad, 2+ is definitely bad, 3+ is, dangerous, and then on the same side, the same level. But so it's a little harder to use, I think, but it is the most popular. And you, and you can tell that it's not easy to use because when you, I'm guessing in the ICUs that you work in, you almost never order a RAS score of just one digit. You typically will -2 to -3 or -1 to -4, and you don't know what it is, but you just know that they're calm at that level, right? I mean, you don't say, I'm writing a fentanyl sedation order to a -2. I mean, nobody does that because nobody knows what a -2 is. It's weird, isn't it? I mean, you use this every day, and you don't think about it that way. Okay, now we're into drugs. The point of the
Okay.
talk.
So, who wants to give an option or want to describe the strategic plan for sedation in this patient? We talked about different options, midazolam, we said, dexmedetomidine.
Speak up.
Speak
You
up.
got to defend what you say.
Propofol, I know. Propofol? Yes? Okay. And in this particular patient, what would be your choice? Number one choice. If you were on shift and the patient is agitating on his tube and you want to make something. Yeah?
If the patient is severely agitated, maybe, I'm not sure what the epileptiform profile is, but maybe go for some kind of antipsychotic just for one shot and see whether that calms the patient down once the pain is settled. And then I would probably go for propofol. The only problem that I have with Remy, which I think is a very good choice here, is that I see this patient needing these things for a long time, and I hate using Remy for a long time.
What do most people use in general for their patients in the ICU who need sedation?
Sorry, I think subarachnoids, I use Propvent purely
What is
because propofol and fentanyl.
Propofol, fentanyl.
Because
Okay.
this is day 4, likely got spasm, it's an ACOM aneurysm. And then actually putting some olanzapine, starting it early, so 2.5 BD TDS. So as you wean off that IV sedation, you've got the olanzapine on. Especially with those ACOM aneurysms, they get a little bit more delirious, and that cognitive dysfunction that comes through with them.
Okay.
And it doesn't affect the QTC that badly.
We just started recently using the Sedaconda and sevoflurane as an anesthetic agent for a quick, no, not the gas man, just the quick reversible, and it's very good for this neurological patient and quick assessment, and yeah. We just started recently, so I didn't experience this.
How do you scavenge it in your...
Because you described the cases are mainly for respiratory distress, and they need to be too for a short
Yeah.
time, they need to be rested tomorrow morning. So I think this is a quite short
Okay.
acting for 24 hours perhaps, and just to really deal with the agitation that you were putting the two you described. This might be the case.
There's no right or wrong answer. You'll all be doing things that I don't do, and
Yeah,
you
but
might
I
be better
also-
than I.
Yeah, keep it simple. Propofol, fentanyl, just small dose fentanyl to make sure the patient is not in pain, 3 microgram per hour or so, and propofol, and top it up with nasogastric quetiapine, and try to wean the propofol later. I mean, dexmedetomidine, I don't know, it's either works or doesn't work. I don't like it that much, but I know a lot of people use it.
So we use as a first line propofol and sufentanil.
Okay.
And maybe if he's agitated because some sort of alcoholic withdrawal, for example, day 4, clonidine, for example,
Okay.
or Dextor, but usually clonidine. I like clonidine more. That's the hospital, our ICU policy. We have sufentanil in Germany.
That's fine.
And who is afraid of giving dexmedetomidine in acute neurological condition? Maybe yes? Okay.
I was thinking if you had any comments to the concerns of at least old animal studies of alpha-2 agonists that cause vasoconstriction in the CNS.
So I think the question regarding the use of dexmedetomidine in acute neurological condition is quite complicated. I think it depends on the purpose of the sedation, really. If you think you have to think about the side effects of the dexmedetomidine. I'm very afraid of bradycardia, hypertension with this kind of drug. This can be an issue in patients with acute neurological condition. And the thing is, if the patient needs only to be relaxed, so because you have to be ventilated and there is no acute neurological condition with something going on like vasospasm, I would rather use dexmedetomidine just to be relaxed and prevent delirium. If the patient needs sedation or sedation to make something for the brain, I will not use dexmedetomidine. Rather, I will use midazolam or propofol for the patient, propofol. And I think it depends on what is your purpose, exact purpose. I'm not afraid of giving dexmedetomidine if I think the patient has not a really severe acute condition in the brain. I will use more sedation if you want to relax the brain rather than the patient.
As an aside, some years ago when dexmedetomidine just became popular, RICU did a prospective randomized double-blind controlled trial looking at dexmedetomidine versus propofol fentanyl to treat patients with neurological conditions. And the goal was to treat them to a RASS of 0 and then assess them at that calm level cognitively. And there it was very clear that dexmedetomidine preserves neurological cognitive state, whereas even light doses of propofol to a RASS of 0, so they're awake and interactive, already have the inability to register very well on a neurocognitive testing module. So even light doses of propofol definitely interfere. That said, there's benefits to propofol fentanyl, so I'm not taking away the possibility of using that, but just as a drug goes, the alpha 2 agonist does not impair the cognitive state like the other drugs do. And certainly midazolam as a benzodiazepine will be
it's almost over.
Typically problematic. Where'd our thing go?
Yeah, they say it's over. So
Well,
sorry. Thank you very much for being there. Sorry.
There's no wrong. I love some of the choices you all came up with.
There's no wrong choice. There's no good choice.
As long as we just go through the algorithm in your mind about why you're giving it and what you want to give, what's the reason.